Excellent. So we are ready for you, Erika, for another third case of clinical sclerotherapy. Yeah, you can go ahead.
Our third place, it is Mr. Harder. He has really large varicose veins. Stell dich einmal hin. We have planned to do, this leg has a saphenous vein reflux filling all this. The other leg has, dreh dich einmal nach da. Nach da. He has a small saphenous vein also on this leg and on this leg. But today, drehen Sie wieder zurück, we are going to treat this. Wir drehen sich mal zu dem. Do you see?
Yes, we can see. We can see very well the groin.
Yes.
The groin.
Yes.
Groin
He has never been treated by his veins, and we really didn't find out why he had this. He was not pregnant, by the way. This
is not a joke by Erika. In NHS in United Kingdom, before you do plain X-ray on a male, you should ask him if are you pregnant or not. This is by regulation, unfortunately.
Okay, so we start doing the exploration. When he came, I said, but you have had like a surgery here or a catheterism or something. No, that Van haben Sie das? He doesn't remember when it started, but it's a long time ago that he has it. And I just want to show you the problem. Of course, you can operate this. You have got a surgeon, you can operate this. But I just start here, mid-thigh. This is the great saphenous vein, if everybody is agreeing with me.
Yes.
And here we have a little perforating vein. I go up, just the anatomy in the first point. And here you see it is large, and in the next moment, here is a vein, a tributary coming in, joining in, and here is one joining in, and here it is really small. And this one is the great saphenous vein, and it is refluxive, but we see that the saphenofemoral junction, we will see it here. Here we have it. It is refluxing, but not so much. It stops a little bit. The most important reflux thing is the accessory anterior vein here. You see them both. This one is the great saphenous. This one is the anterior accessory. And we go inside to measure.
Perfect.
And you really see a large reflux. So if a person carries these kind of very extremely tortuous varicose veins so many years in a country where all the thing we do is operating, you can imagine that he didn't want a surgery. And this is why he came here, because he knew that I'm doing it different. So I am completely with you, Joseph. You are thinking this one would be a wonderful case of putting adrenaline around the vein, and I'm thinking of doing it anyway. Because with adrenaline, you could reduce the volume of this.
Absolutely. And further, yes, and further, as long as you've got a secure cannular access to the primary source of reflux, I think it would be fabulous. And the other thing is, as you may recall, Dr. Erika, when you visited me in Sydney, I love to, rather than flush the cannula once you've got access, rather than flush with plain saline, I actually flush with 0.5% STS, which commences, firstly, causes vasoconstriction. Secondly, gives you a degree of endothelial lysis, and thirdly, increases the power of your sclerotherapy, of your foam sclerotherapy. Finally, it also reduces the amount of volume required, and this is obviously an aneurysmal dilatation and somewhat a venous. It's been quite existent. I'm wondering about the inferior.
Just a second, I have to ask the patient something. Vertragen Sie beim Zahnarzt die örtliche Betäubung?
Ja.
Gut. Ich würde nämlich, wie wir gerade diskutieren, ein bisschen Adrenalin ganz verdünnt herumspritzen. Dann macht sich nämlich die Vene, zieht sich schon mal zusammen. Ja? Und dann kann man das Ergebnis verbessern. Yeah? I just had to ask him if he, normally when you go to the dentist, you receive adrenaline in the local anesthesia. And some people don't react very well to adrenaline. So I ask always if they tolerated the... So my plan would be, if you see this one here, this one is the accessory anterior healthy in this place.
Yes.
And then going on. So I would try to cannulate, it ends up in this one. I would try to cannulate this one and to cannulate the great saphenous with Avokas, wo ich dann auch zwei blaue Infusionsnadeln ran.
Can I play the devil advocate in this case and just ask, can it be an element of pelvic congestion syndrome in this patient, or do you think the reflux is only from saphenofemoral junction? Can it be?
I think it is really only the saphenofemoral junction in this place. You see, it is very, very obvious that it comes out here, but we can just have a look. This would be the epigastric vein.
Yeah, is it not the superficial inferior epigastric?
I mean, it comes from above. Haben wir jetzt, sorry, wir haben jetzt ganz auf 10 aufgezogen. Nee, das 20er, auch nicht davor. Und die müssen das mit 10 Millilitern erstmal auf... we are preparing the adrenaline. I will just step out and you discuss something, please.
Okay.
So what's your feeling, Joseph?
Yes, Professor, I think this is a perfect case for the application of what we refer to as empty vein sclerotherapy. And in essence, it entails, firstly, a vascular access. So you need secure access, either via an 18-gauge angiocath or any other. I actually, believe it or not, just use hypodermic needles for vascular access, and I would gladly show you at some time. The point is secure vascular access, firstly. Secondly, inject a very powerful and potent vasoconstrictor, and that would be STS solution. I would use 0.5% STS solution, about 0.5 ml or 1 ml, doesn't take much at all. And then, of course, I would infiltrate with tumescent anesthesia, and the tumescent anesthesia I would use would be 1 in 2 million adrenaline and 0.04% xylocaine. I've been using this concoction for the last 20 years or so. And also, of course, we need to, by rights, monitor the patient. So you should at least be doing basic vitals, pulse, blood pressure, and oximetry, because occasionally you will get an intravascular bolus of adrenaline, even though at 1 in 2 million, that could be enough to cause a tachycardia, which is not a problem. But every now and then, if you're not careful, you will get either VT or even VF, and you've got to be there and ready to resuscitate the patient. So I think you need to make sure you've got a crash cart trolley and be ready.
Absolutely, absolutely. So you create a spasm around the vessel to collapse, and then you do your sclerotherapy at this stage.
Absolutely, and I can show you in many instances where we do it. You start with a 10 or 20 millimeter diameter vessel, and when you're ready to give the foam sclerotherapy, it's down to about 2 and 3 millimeters. And if you do the calculations, you can obviously extend a hell of a lot further. Back to you, Professor.
Okay, thank you very much. And Erika, we're ready.
Yes, so we didn't have that prepared, so we had to do so. I took a 2 ml, 1 ml ampoule of adrenaline, and I diluted it in 20 mils of saline, and I took 4 mils of these into 1 liter of saline. So I have diluted it to It is 1 to 0, 0, 0, 0, lots of zeros there. So to have a really diluted concentration of adrenaline. And
that's
now,
1 in 4 million.
Now I will prepare the field. I always put the jelly first, and then I apply from both sides. I apply the, because if you put first the alcohol and then the jelly, it tends to move away. So
I like the use of the spray, Dr. Erika. That's a brilliant idea. Where did you get that from?
The big spray.
Yeah, the alcohol spray.
This is a German producer.
So chlorohexidine spray, which is a general antiseptic that we use in theater if someone is allergic to betadine. This chlorohexidine spray. We usually sterilize the probe, the duplex probe with it, the endoscopy. A lot of tool can be sterilized this way. Chlorohexidine spray.
Excellent.
Yeah.
Now I will introduce an avocado in the great saphenous vein. So jetzt kommt ein Nadel rein. No? Nicht weinen, nicht schreien. Nix.
So now we are injecting the adrenaline.
No, I putting the avocado inside the vein. Kannst du mal die Nadel because
if you inject adrenaline first, you will lose access.
Precisely.
Yeah.
So it's just achieving secure vascular access.
Yeah, no, it's a very nice idea because you decrease the amount of lumen of the vessel and expose the intima, and you just fire the sclerotherapy to the intima. So surely it will get a powerful impact. It's a very nice idea. You've been using it for 20 years.
Yes, sir. And what's more is that it reduces your demand for active dose of medication. I actually use a maximum of 5 mils of foam in any one given treatment session. And that because you're using less drug, you're going to reduce your incidence of adverse effects accordingly. And you do not lose benefit or efficacy or if you like, results purely simply because you're maximizing your return.
Absolutely. This is really a great advice to all our 100 candidates who are listening to us on the Zoom and another couple of hundred on the Facebook. So this is a great advice. Yeah, great advice to minimize the dose as you can. And I like when you mention when you're making foam, you are manufacturing a drug. So there is a process that you need to be professional and you need to minimize the amount to get the maximum better success and to have really the complication away from you. That's a great advice, Joseph.
Precisely. I thoroughly agree, Professor.
Yeah.
Okay, so I have put 2. Do you see them? One in the saphenous vein and one in the superficial. This one. But I hope it will keep there.
Okay.
Because
that's extremely important. And as you're saying, Dr. Erika, you need to have secure access, because if you lose that access, you've lost the opportunity to actually intervene. It's not the end of the world because you can always come back and do it, but you really must ensure that you've got secure vascular access.
Yeah.
So now we are taking out of my mixture, we are taking 20 mils. I don't know if I will need so much, but this is the mixture with the adrenaline.
Yep.
And I will take a brown needle again.
Yes.
Excellent.
Yep. And Dr. Erika, I would use anywhere from 20 to 200 mils of tumescence. There's absolutely no harm in using adequate volume to achieve the degree of compression.
Yes, and yes, this is a real little zone. I would just take. I will start with 20 mils, and if I need more, I will go on and have more of
Excellent.
it.
So I'm very eager to see where do you inject it, Erika. Yes, please.
Yes. I am injecting it You see, this is the aneurysma of the accessory anterior. Yes.
Yeah.
And I will go beside the vein, not to go inside, fix normal. And
start infiltrating.
You see the infiltration, yes?
Yeah. Yeah.
Yep.
It is.
Is this the same technique that you use, Joseph?
Exactly the same technique. The only variations are vessel, access size, access, whether I'm using a needle or an 18 gauge angiocath. And I just add, I also add a tincture of xylocaine, just so it produces some anesthesia. And you also get vasoconstriction with the xylocaine as well. This is exactly the same. And I would use in a session, on average, for a sclerotherapy session, I would use anywhere from 200 to 500 mils of tumescence to actually achieve adequate compression. We all use it with endovenous laser ablation, but I think it's a shame that you don't take advantage of the same principles here with sclerotherapy.
Yeah.
I can tell you why. This is, I can't put local anesthesia in a patient who is driving a car afterwards. In
Precisely.
Germany, this is not allowed. So I would, when I do my bone sclerotherapy, people usually afterwards go back to work or something like that. And so I couldn't do this if I put local anesthesia. And I think that the volume of liquid there, I'm with Joseph, is a 1 point. But if I put 200 mils of liquid in a leg, this is a question of money. Because normally then I use a roller pump thing, like we use this pumps we used to do the infiltration in case of an luminal treatment. And this goes within the price. But when I do sclerotherapy in Germany, I charge 80 euros, which is the highest I am allowed to charge. And you can imagine that I won't pay the complete. Alles gut? Yeah. I wouldn't, if I put the roller pump to work and everything I need around it, it will cost me more than I'm earning for it.
Absolutely.
This shouldn't be the thing to decide why to do something or not. But at the end of the day, you have to be able to have a reimbursement.
To be financially sustainable. Yeah.
Yes. And now you see that the aneurysmatic thing is gone.
Fantastic.
Yes, it is really gone. It's really small. And now I will make my 3% foam. And as always, when I do a film, what will happen is that this one will have gone, I hope not. But yes, is my foam. Brauche hier eine Unterlage und dann nochmal
And if it does, Dr. Erika, the risk is really very small, because it just means you may have to come back and do it on a separate session. It's a very small price to pay for the tremendous benefit you get that from because if you were to inject that aneurysmal dilatation with 1, 2, 3, or 4 mils, let me tell you, all of that is going straight into the deep system and then across the right to left shunts, and it's not worth the risk to and for the patient.
Yeah, absolutely. It minimizes the amount of foam dramatically.
Precisely.
We will see what happens if it's intraluminal or not.
Yeah.
And Dr. Erika, this injection that you're about to give is both diagnostic and therapeutic. So diagnostic, because you'll see what's happening, and you'll see what the size of the vessel is and whether there's stasis or not. And of course, it's therapeutic.
Yeah, absolutely.
So
in the beginning of my career, we used to deal with these cases with surgery, which was horrible.
Yes, absolutely.
So what Erika is doing is quite magic.
See that it is gone up to here and here and here.
That's fantastic, Erika.
And I will do next step. Ich brauche eine Nadel, ich brauche eine Spritze. Ich nehme die Linie nochmal 3% auf die Null.
I'm very happy with this case because a lot of the candidates are vascular surgeons. So this definitely shows the way for massive varicose vein can be treated with endoluminal technique. Yes.
As you see here, we still see a vein with the eye. And I will go here inside and I will give a further dose. I think I will have extra vasated.
It's a great case, Erika. Great case.
Thank you to hear so. And now I will go to the great saphenous vein where I have introduced another
vascular access.
Trick. In this case, I will just take the rest of it into the larger, which is 4,5 mils. Ich brauche einen Tupfer und ich brauche ein Schallgel gleich. Tupfer brauche ich jetzt. Oder Schallgel. I have two great assistants with me, I have to tell you.
Yeah, please thank you, the two assistants.
And a great patient.
And a great daughter as well.
And Dr. Erika, the only other thing, as you know, when you came to my practice, you know, I love to use ice, sterile ice to actually.
I can't talk now. I have to do something. So now my assistant is closing the distal GSV.
Yes.
Oblige the thing I am injecting to go to the head. Yes, she's closing this here with the digitally, and I can show you that the volume has gone to the saphenofemoral junction perfectly. Of course, in the femoral vein, you see a little bit of it. It was able to be seen. No, not so much.
Excellent.
It's just until the junction. And what I do now, because I'm happy, I do like this. I take this out, kommen Sie hier
compression. Yeah.
Yes, I do. And I compress here, like very relaxed. I stand and talking to the patient and put my body weight, body weight on the, I come down, so you see me. Body weight on the leg, just to make sure there will be no reflux into the just formed area. And I was very impressed to see that there was really little foam in the common femoral vein. Normally, if you do the sclerotherapy, you see a lot of it. And this is because I used 3%. I stopped injecting when I saw it was there. And the vessels were really contracted by the adrenaline.
Excellent.
So that's it. Yes.
Excellent. So what is your trick with the ice bag, Joseph?
Ice acts as an analgesic. It acts as a vasoconstrictor, and it also we also use it for compression. So you can see where Dr. Erika's hand is in the groin. I've got these nice flat cubes of ice, which I use to just gently compress. So you get hypothermia, which basically vasoconstricts. It acts as an analgesic. The patients love it because it makes the place feel good, because immediately post-injection, you know, you're getting your hyperemia and your rubor and the dolor and so on and so forth. So, you know, they're just little things that do assist. And of course, the best way to minimize bruising and bleeding is to use a simple ice and cold pack. So it's a little additional item which really makes a huge difference. I've been using it for years, and I love it.
It's a collection of fine tips and tricks that will get you
precisely.
Yeah,
and as you can see, Professor Dr. Erika has really demonstrated a first-class approach to quite a large aneurysmally dilated venous almost malformation. In simple terms, establish secure vascular access. Second, apply some perivascular compression by way of infiltration of pure saline with or without adrenaline. The adrenaline acts as a potent vasoconstrictor, and I don't think you can really get any better than that. And then thirdly, inject according to how you can see.
Okay. And the
Absolutely.
next thing we are doing in this case, I have learned, this is completely empirical, because if you put a stocking until the groin, the region of interest is not compressed. And men usually don't like to have trousers, I mean panties.
Yes.
So I have changed, I don't know how Radler was in English, Clara. These things you can put on when you ride a bike. You know, this is like a short, yes, a compression short. You can buy them in the bitterkopf unten lassen. And patient shouldn't elevate the head because he's doing muscle contraction until everything is inside. And can we put the second mobile just to look? Muss jetzt gar nicht so, aber einfach, dass Sie das Bein sehen. We put compression in the first to the leg, then we put didn't keep the name with me. We put this things in the groin just to extra compress, and he gets a short trouser on it. And as to my experience, I'm doing this with the extra trouser when I treat the groin since the year before COVID, so 19. Yeah. And my experience is that the results are better when I do recurrent varicose veins in the groin, which this looks like really. So we have the stocking until this point, the highest as possible. We put extra bandages there, fixed by the trouser, and then we put the other one on top. And I think that this could help keeping the things closed. And you see, even if everything is being performed, the patient at least is 5 to 10 minutes recumbent before he gets up. Yep. And sometimes I say something in German, I say Kopf runter, put your head down, because if you put the head up, you really press with the stomach muscles and you put the blood back to the leg. Okay, so sorry for interrupting, but I had to
no interruption at all. I have really to congratulate you, Erika. It's amazing, because in the beginning of my career, this patient would have been a typical patient for varicose vein surgery with a procedure that usually will lose 2 units of blood, and he will stay with us in the hospital for 3 to 4 days. And the complication of post-operative hematoma, and today I've seen amazing things, really. It's like magic, Erika.
Okay, thank you so much.
No, it's true.
I see a very interesting question there from Baha Rifai. Yes. How many days would you wait? This is a real good question. For the dosage I am allowed to apply, it's 24 hours, because you can apply 10 mils of air in 24 hours. But I normally let the tissue react and wait 1 week for the next session. This is in normal varicose veins. In these transtibial varicose veins, I do it every second day, because there is no tissue. I have to really close the point. And when I used to do it with weeks in between, the results were worse. So I will see the guy on Monday and on Tuesday, if necessary, just to redo it. But this is the transtibial perforating vein, which is a completely different approach. In normal situation, I wait 1 to 3 weeks. I often do it like I do the second look and treatment when they come back for the control of the hyperpigmentation. Yes? Okay.
Yeah. Fantastic. So a lot of congratulate you, Erika, about the great demonstration of 3 of the most difficult cases, and to congratulate Joseph for very nice technical tips and tricks. So
and I thank him, because I learned this thing from him. I learned the blunt needles from him, which seems to be a stupid thing, but it's very important. And I learned the adrenaline which really made change in my treatment of the patients.
Yeah. You know, when we get puncture in United Kingdom, accidental puncture by needle, we have to fill what is called puncture form. And with puncture form, it takes about 30 minutes to fill it up. And they take blood sample to see what is our virology situation. So to save this step is like saving for you 1 hour and puncture. So this is very good. So I know we're nearly reaching 2 hours. It was really fascinating. I would like to invite you, Erika, to conclude and give us your summary, your experience, and Joseph. And at the end, I would like to thank MOH. So back to you, Erika, to summarize fascinating day.
Thank you, Mohammed, because you're always a real fantastic commenter and organizer of the session. Thank you so, so much. I enjoyed it as always. Thanks, Joseph, for not only having been my teacher in this part of treatment, but for the very, very good comments. And I can only recommend everybody to visit him in Sydney, because I have never seen, I think I'm good organized in my office, but I've never seen such a good setup also for teaching, because he films everything. He has 2 ultrasound images. He has a complete room. He has everything. It is gorgeous. So if you find the time and happen to pass by Australia, which is just around the corner, you should stop by at Joseph's place and learn there. And I'm very thankful to MOH and Sigvaris, because they opened the doors to this hand-on workshops. And I think the results this year have been so good that we will go on with them next year. We have still one in November. I think it's the 21st. I don't know exactly, where we will show compression in case of ulceration of legs, how to compress the legs in people with ulceration, and how to make a punch biopsy, needle punches, and put skin on the skin, on the ulcered skin. I'm sorry, my English has gone today.
That's all right. Sponge grafts.
Wonderful Spanish punch grafts. Yes, a wonderful Spanish colleague. And we'll just come back when Joseph has finished. I tell you the date and the hour exactly. So Joseph, the mic is yours.
Yes. Oh, well, it's a good evening from me here. It's midnight. I've got to say, this is my first medical online hub experience. So I want to take this opportunity to thank, obviously, Mahmoud El Gadban for the invitation. I want to thank you for your kind moderation and control, Professor Omar. But more importantly, Erika, I would like to share with the world and my colleagues here that you are truly a beacon of hope and inspiration, and a first-class educator and teacher. And this is very, very evident here today. I have learned so much from you, and this is what it is. This is what it's all about, with collegiate sharing and so on and so forth. The invitation is always open to visit us here in Sydney, Australia. I would be delighted and honoured, to say the least. I love my work, and I'm very passionate about what we do. And sure, we're always students. And thank you for your very kind invitation, Erika.
Thank you. Thank you so much. I am November the 6th. Wow, 4 p.m. Wednesday, November the 6th. It is with Elena Conde from Spain. And this will be very interesting, because it is an easy to do, cheap to do skin transplant. And I will talk about the possibilities to do a compression on ulcerated skin, which always with a regular stocking is not as easy, but there are lots of solutions. So thank you very much to everybody. And Omar, Mohammed, the mic is yours. Thank you.
Okay, so I would like to thank everyone. I would like to thank Dr. Mahmoud El Ghadban. We are fortunate that he was unable to be with us today, but he sent all his best wishes to us. I enjoyed thoroughly every femtosecond with Erika Mendoza. And I really enjoyed the wisdom of Joseph. And I think the platform of MOH is fantastic because it is clinical, it's applicable. You can use it the second day. We show you direct relation of management to the patient straight away. And this could never be beaten by any lecture, any textbook, or any congress. So I really like the idea of Medical Online Hub. I'm very thankful to Sigvaras and our dear organizer, Prime, for his excellent audiovisual and his excellent effort. Thank you very much. We hope to see you again and wish you all the best.
Oh, also to you. Thank you.
Thank you.
Thank you.